We are pleased and appreciative to participate in this important event. My name is Don Dow. I will share our experiences working in hepatitis C surveillance, screening, and linkage to care in Ho Chi Minh City, Vietnam. Our initiatives also involves hepatitis B. However, for this presentation, I only focus on hepatitis C. The disease burdens of hepatitis C in Vietnam is considerable. In 2017, based on modeling data performed by Vietnam's Ministry of Health and WHO Vietnam, there are approximately 1 million chronic hep C carriers in Vietnam. That is about 1.1% of the population. However, in the high-risk groups, hepatitis C can afflict up to 39% of those populations. Of the total hep C cases in Vietnam, a negligible number has been diagnosed and thus treated. In response to the significant disease burdens of viral hepatitis, in 2015, Vietnam's Ministry of Health released its first national plan for prevention and control of viral hepatitis for the period 2015 to 2019. This national action plan is particularly important in the country because of its political system and decision-making process. The release of the national action plan indicated that viral hepatitis at the national level has been recognized as an urgent and significant public health problem, so all the lower governmental levels can now address the disease burdens. Vietnam is a developing country in Southeast Asia, as shown in red on the map. Following the National Action Plan, we decided to help address the huge disease burden of viral hepatitis there. Strategically, we began by creating a comprehensive multi-year community participatory and research-based program to generate reliable baseline data. And through this baseline evidence-based data as groundwork, we then build a coalition of key stakeholders who will then engage, advocate, and influence policy changes among stakeholders, including Vietnam's Ministry of Health. So we selected Ho Chi Minh City to demonstrate this evidence-based advocacy strategy in influencing policy changes. Ho Chi Minh City is located in southern Vietnam, as illustrated here. It has a population of 12 million. It is a prototype for Vietnam. This slide also shows an overview of the study designs involving three different phases, 1, 2, and 3, in a stepwise fashion with a corresponding sample sizes from small to large. We deploy a public health method, probability proportional to sample size or PBS, to representatively sample 20,000 adults 18 or older out of 12 million residents in Ho Chi Minh City for this study. Major stakeholders and overall collaborations are comprised of government and public health sectors, NGO, and private entities. And this is a model of private and public partnership that we also wanted to demonstrate it through this study. Ho Chi Minh City Department of Health serves as an umbrella providing an overarching legal and cultural support. With the Vietnam Viral Hepatitis Alliance, an NGO is responsible for funding, study design, etc. Pham University of Medicine, a local university, is responsible for outreach activities as well as ILB approvals. Medical Center, a private sector, is responsible for lab testing and provision of linkage to care. The program design is following. For the pre-screening and screening phases, as mentioned, we deploy PBS to select 100 wards out of 322 wards in Ho Chi Minh City. Under each ward, we then selected a certain number of commutes. Under each commute, we chose a certain number of neighborhoods, and under each neighborhood, we invited 100 adults or 2 adults per household for a total of 50 households. And again, this is a PBS design for a representative sampling of a population. After we go through all of these selections, our outreach teams go to each household up to 3 times to invite for participants. Of the invited individuals, if they agree, they will come to a local clinic where they are given educational booklet, sign the consent, answer KFB questionnaire, get their blood drawn, and after they did all of this, they receive incentives and wait for the results in 2 to 4 weeks. Failure to participate is also defined as shown on the slide. In the post-screening linkage to care stage, the screening participants return to the same local clinic where they have their blood collected to receive the result envelope and provide signatures to certify that they have received the results. In the result envelope, they are provided the result interpretations and linkage to care referral network informations as shown in these boxes. Our care navigators will then call back to the screening participants at the predetermined time points for follow-up. For those who have not been linked to care, they are given appropriate guidance as next steps. Along the cascade of linkage to care, we again employ care coordinators for navigation. These are some of the pictures showing a local clinic where screening participants come for registration and answering KAB questionnaires and subsequently have their blood collected by mobile phlebotomists. This slide demonstrates an example of how we have been engaging key stakeholders through national conferences for healthcare providers and community education seminars for patients. And here are the results of the screening and linkage to care. The prevalence for anti-hepatitis C antibody positivity is 2.2%. Of those, 70% are Hep C RNA positive. This is translated into 1.54% active Hep C infection prevalence in Ho Chi Minh City. 69% had anti-HBC, and that is antibody to the core total of hepatitis B. 5.6% had HBsAg positivity, and 55.7% had central obesity. These statistics have implications in the clinical management of hepatitis C. 91.6% had low to middle income level. That is, they earned $340 per month or less. In comparison, the cost for a treatment course of hepatitis C with DAA in Vietnam is $1,500. 71% had less than high school education. Regarding linkage to care, 92% reported receipt of program follow-up materials, 91% had insurance, and 61% consulted a hepatology clinic. Of those who consulted hepatology clinic, 31% used insurance to pay for Hep C clinical management. Hepatitis C screening and diagnostic costs. Point of care or rapid test cost is about $1.30, and this is not widely used in community in Vietnam. Hep C PCR cost is about 50 US dollars. Screening test is currently not covered by the National Health Insurance, and patient would pay for 50% of the treatment cost for Hep C treatment with DEA in Vietnam. So the copay is 50%. Current challenges for Hep C elimination in Vietnam. Here I just highlight some of the major challenges. There are inadequate workforces and advocacy groups dedicated to viral hepatitis elimination efforts there. Because of these screening tests yet to be reimbursed by national insurance, for example, treatment cost is relatively unaffordable by most who need it. Lack of a formal surveillance database for viral hepatitis at multiple levels of healthcare systems in Vietnam. Focus and investment in viral hepatitis have been further interrupted by COVID-19 pandemic. Financing challenges have always been the case. Funding for Hep C testing and treatment scale up is almost non-existent in Vietnam. Lack of incentives to take care of patients with hepatitis C from physician and healthcare systems um, is also noted. Lack of decentralized care for Hep C in community and underutilization of clinical care coordinators for Hep C screening and access to care. So for us, our next steps for Hep C testing and treatment scale up include, and that is we have been grateful to be able to participate in HIT study. This study is being led by the Coalition for Global Hepatitis Elimination. The aim is to influence policy change among key stakeholders through hepatitis B and C elimination tool. We also putting together um, a program entitled Making Hepatitis B, Hepatitis C History in Camo. This program aims to eliminate Hep B and Hep C in Camo Province, Vietnam. Camo has a population of 1.3 million, and most of the population there are underprivileged. And this program is being supported by a local philanthropist. And this slide is my acknowledgement slide. And I thank you for your attention.